Hi, everyone. Welcome to our April NAHA webinar. Today we have Dr. Jessie Cavanaugh with us to go over some research results of a study that she has completed. So we're super excited to hear these results. I just wanted to remind everyone that it is a conference year. We'll have our Beyond Aromatics 2025 conference this October. Dr. Cavanaugh will actually be presenting at the conference as well. So we're super excited about that. For anyone interested in wanting to purchase a conference ticket, you can do so at conference.naha.org. And yeah, I just want to hand the time over to Dr. Cavanaugh. How are you?
Good, good. How are you?
Good.
Good. Okay, I'll go ahead and get started. Welcome everyone to today's webinar. We're going to, as Michaela said, go over a clinical trial that we have recently finished. This is a NAHA sponsored study. So this is all of your membership fees in action. This is kind of the practical component of what they do to help grow the aromatherapy community and the body of knowledge. Um, I'm going to briefly kind of just go over a little bit about why this is what I do. I know that I already know quite a few of you. We've met at conferences and other webinars and so on. But my entire academic background is clinical research. And from the get-go, I've had an emphasis on research with children, pregnant women, vulnerable populations that tend to get overlooked in clinical research. And so, all the way back from my undergrad degree in environmental health, my emphasis was the benefits of uh, beneficial microbes in child growth and development. My PhD dissertation was a clinical trial on the use of essential oils for pre-procedural anxiety with children with an autism spectrum disorder. So again, I really like digging into these underserved populations and digging into these almost untouchable areas so that we can provide that clarity and that information so that we can do a better job with them. Full disclosure, my day job is actually clinical research as well. I own the Nutraceuticals Research Institute, and we conduct research studies for the natural products industry. So we work with a wide variety of companies from around the globe who, want to better understand how their products work, answer a lot of these questions that we have. So in addition to being the research committee chair at NAHA, that is also my day job that I do as well. So it is day in and day out my full-time approach. And this is just that overview of what we do. But I want to dive right in because I know your time is valuable. I don't want to spend a whole lot of time on all of that background information. I want to dive right in and talk about why this research is so important, why this is something that's important to NAHA, why this is something that is continuing to be important to NAHA, and why it is so critical that all of you are involved in not only the research process as we're working through all of this, but also helping to disseminate this research among our peers and our colleagues and lay people using essential oils, whoever that might be. And a big reason for that is that pediatric research is dramatically overlooked, and it has been for quite a while. The World Health Organization actually has an entire section on why this is so important. And one of the reasons for that would be that for so many years, for literally centuries, we treated children as though they were just miniature adults. So whatever we did for an adult, we just did a smaller version, typically by weight, and we gave it to children, and we expected that to be effective. We really haven't fully understood child development. We still don't fully understand child development, but we really haven't had any progress in understanding child development until the last 100 or so years, where we began to understand that children are not just born with fully mature organs and organ systems, that they are more than just small little adults, that they're actually in a perpetual stage of growth and development. And so what that means is we have to account for not only their physical size that's different, but we have to account for all of these developmental differences. The other thing that we have to account for that's pretty unique for aromatherapy is we also have to account for their psychological differences. And that plays a little bit of a role in conventional medicine when we're talking about, using aspirin or Tylenol or some over-the-counter treatment. Then obviously there is the placebo effect, there is the mind-body effect, but it's really not something that we see have a dramatic effect until we talk about something like aromatherapy, where this is a sensory input that we're using in many cases to achieve a therapeutic outcome. So those psychological differences as well, their comprehension of why they're sick, their understandings about being sick, all of those play a role in whether or not we're going to achieve efficacy as well. And if we don't have good, solid evidence that is specific to this individual population, we're not going to achieve that goal of safety and efficacy, which I know all of you have heard me harp on that. That's kind of the twin origins of my entire career is how do we achieve safety and efficacy, particularly with children, with our natural products. So up until about the 1980s, we fully excluded children from research studies. In fact, they were called therapeutic orphans, basically because there was no information about how we were treating children. And this is across the board. This is not just in natural products. This is across the board with everything that has to do with children, child health, child development. Essentially, when children came into a care provider's office or a hospital or wherever it might be, then the information that was used to determine that standard of care was extrapolated from studies conducted on adults. I know that y'all have heard me previously talking about when we have at NAHA conferences, when we've talked about research we've conducted on pregnant women and in female populations, females were also typically excluded because of the potential to become pregnant. So that was something that kind of in the 70s and 80s also we started to see that tide kind of shift as we realized you can't take research on this group and apply it to that group because people are fundamentally different. So taking these adult studies, figuring out what works in adults, and then just applying it to children obviously doesn't work. So in 1998, which again, it takes a while, change is slow. 1998, the National Institutes for Health actually mandated that in any studies that they fund, children have to be included. This was a big step because prior to that, they made recommendations, they suggested it, they issued memos, things like that, that are great in concept, but not really effective tools. So they started tying it to money. If you want to study whatever it might be, and the National Institutes for Health is going to be funding it, you've got to have a valid reason for excluding children. And that valid reason cannot be, kids are difficult to study. It has to be a legitimate reason, such as this is a disease that only affects adults, or we don't yet have enough safety data for children. So you had to really substantiate why you were excluding children from that research. That helps. That helps to shift the tide. But also think about how many different things we use that were approved and on the market before then. In 2002, then there was also a bill passed to help kind of retroactively go back and look at our medications and say, okay, what does this look like for children? Is it safe in children? Is it effective in children? What kind of approach do we need to be taking? Do we need to adjust the dosing up, down, less frequent, more frequent? All of these parameters. And so that came with a big initiative to go back and re-study a lot of the products that are already being used to treat children. And again, we made strides, we made progress, but still today, the overwhelming majority of medications, if you have a child, especially a young child, and they were to go into the hospital to be treated, the overwhelming majority of medications they would be receiving are prescribed what they call off-label. And that means that the FDA has not approved them for that purpose. They're approved for some other purpose, for some other age group, for some other illness, for whatever that might be. And this is routine. We see this in walk-in clinics, medical offices, and so on. The American Academy of Pediatrics has page after page of instructions for how to try and do the best you can with the fact that these are being prescribed off-label. In some populations, especially the younger we get and the more serious the illness is, that number goes over 90%. So if we're talking about infants who are going into the NICU, over 90% of the medications that they're given could be prescribed off-label. So that means it's basically a loophole with the FDA. It means that we haven't conducted studies on these products. They're getting FDA approval so they can be sold, but we don't know what a safe dose is. We don't know what an effective dose is, and we don't know how to give anyone enough information to provide informed consent because, again, we can't tell them everything that can happen. So studies have evaluated what this means and why this might be problematic. In adults, using drugs off-label leads to about a 44% higher chance of adverse effects. Again, because we haven't conducted those phase 3 studies on these medications to figure out what risks they pose when someone is using it for this particular purpose. So these are just things that we've not yet identified because we're using them, but we're not studying why we're using them. We're treating everyone like a guinea pig in an open label study that's not collecting any data and not actually leading to any change. When we get down to children, though, we see that dramatically increase. So our relative risk is about 3.44. Now, a relative risk is simply your ratio of the risks in a reference population and the risks in the population you're looking at. So a relative risk of 1 would mean that they have the same risk. Y'all might remember when we did the lavender tea tree research and we were looking at the potential for those essential oils to contribute to prepubertal gynecomastia. The ratio that we came up with was pretty close to 1. And that basically meant there's absolutely no difference between kids who are exposed to these oils and kids who are not in terms of who develops it. So 1 is your equal goal here. So 3.44 is pretty bad. It's pretty bad territory to be in. This is not just about pharmaceutical drugs, though. We have the same issue in the natural products world. We know from NHANES data, the most recent being 2018, that over a third of children in the US are using natural products. You'll notice that the most recent data is 2018, which happened to be just a couple years before we had a whole pandemic, which dramatically changed people's approach to health, people's approach to well-being, people's opinions about natural products versus pharmaceutical products. And so that figure has dramatically increased since then. So we have a lot of children who are being treated with natural products. In fact, in the natural products industry, children are a priority target because we know that they are some of the most likely in a family to be using natural products. We also know that kids are more likely to be getting sick. Their immune systems are still developing, they're in school, they're sharing germs, they don't quite have the same sanitation that we have as adults. A lot of different factors contribute to that. But as they're developing their immune systems, they're more likely to get sick. Parents are more likely to be concerned about what they're putting in their kids' bodies, especially in light of all that off-label use of prescriptions. And so they turn to natural products. We also know that in the last couple of decades, essential oils have genetics, again, especially in children, especially when we're talking about treating children. Researchers have looked into why this is, what parents are using these essential oils for, what types of conditions they're treating with these essential oils. And some of the most common are things that we tend to see on a regular basis. A common cold, for example, digestive complaints, dermal conditions, sleep conditions, anxiety, things that we tend to talk about pretty regularly when it comes to kids and natural health. And when you think of any of those conditions, you can probably immediately think of which essential oils you might be turning to look at some of these. Digestive complaints, I mean, these are some of the most common things that we look at. These are in some of the most basic introductory aromatherapy classes, these oils that we're using. You can also see right off the bat when we talk about common cold or any sort of respiratory conditions that we're going to immediately run into a lot of friction in the aromatherapy industry, in the aromatherapy community, about which oils you can use for these purposes, whether or not they're safe to use, what age groups you can use them in, and so on. So that kind of leads to why this is so important. But what we have here is, again, we've got the same therapeutic orphan status. And that is why we have so much controversy about what is safe to use and what is not safe to use. Because what we have is a whole lot of individual stories, a whole lot of individual case studies, nothing that's really cohesive in putting them together Nothing that is saying if this outcome happened, why did it happen? And what are the patterns that we see here? What leads to whether or not children are going to respond to this intervention or not respond to this intervention? And all we have here are individual cases, a whole lot of speculation and opinion, and not really much in the way of clear scientific research. Now, one of the reasons this is problematic that we can't, again, just pull that information from adult studies, because if we look at adult studies, especially if we're talking about the common cold or any respiratory condition, COVID, the flu, RSV, any of those, um, we do have a lot of information about using essential oils in adults for these same purposes. But we can't take that and generalize it to kids. And this is one of the reasons why. In fact, this is also one of the reasons that we see that increase in that risk ratio when we're looking at using things off label or generalizing them inappropriately, is kind of how we refer to it in the scientific world. Um, and that is that children are so much more vulnerable, especially when we're talking about inhalation products. Now, there's a different set of vulnerabilities for each type of application we can look at. We can go into what this looks like for dermal applications, the developmental of the dermal microbiome, all of that. We can talk about what this looks like for ingestion. But for inhalation, which is one of the most common ways we're using essential oils on children, we have some really unique challenges that we have to address. The first one is just the sheer quantity of air that kids are breathing in. A resting infant's air intake is about twice that of an adult because a lot of this has to do with, again, the rate of growth and development that's taking place. Their respiratory rate is faster, they're breathing in more air, quality or quantity of air that they're inhaling is greater, which means anything that's in the air, an essential oil, an environmental toxin, whatever it might be, secondhand smoke. This is why so many of those factors are so much more dangerous for children than for adults. Whatever it is that's in the air, beneficial or otherwise, they're going to be getting a much greater dose. And again, this is not something they just automatically grow out of. They are slowly transitioning out of that stage throughout childhood. By the time they get to elementary age, they're still taking in about 1.5 times the amount of air that an adult is taking in. So, what that means is that the air quality that a child breathes is so much more important for a child than it is for an adult, which then means if we're looking at treating a child through air quality, through inhalation, through what they are inhaling, then we have to pay close attention to the quantity that they are inhaling, as well as the quality of the air around them within that particular exposure area. This is another reason that essential oils in the classroom are such a hotly debated topic, because we have these closed off rooms, a lot of children in a closed off room, and then we start pouring these essential oils into the air. They're going to be breathing in a lot more than the teacher who might have chosen which essential oils are going to go into the air, or someone down the hall. So we have to look at not just what works for an adult, but what is working for the kids that have that exposure. They also have a higher proportion of rapidly growing tissues. In other words, their bodies are growing and developing. They're growing more physical mass, their internal organs are maturing, their metabolic pathways are maturing. They don't have the same metabolic pathways that we have. So they're not able to inhale certain things, metabolize them, and eliminate them in the same way that adults are, which will often mean that whatever chemicals they breathe in, whether they are toxic chemicals from the environment that we don't want them to be exposed to, or whether these are phytochemicals from an essential oil or any other plant matter, whatever that might look like, whether we want them to have that exposure or not, they're going to linger in the body for longer, which is going to dramatically impact how we actually administer whatever treatment it is that we're looking at using in kids. So this is why we can't just douse kids in essential oils, call it a day, and move on. We're going to see a lot more negative effects. Those might just be simple, like irritability. They are going to be more likely to develop a headache because, again, they're going to be inhaling more of that than we are. It could also lead to other more serious effects, such as respiratory distress, or some other problem within the body. So it, again, can be mild, it can be severe. Regardless, it's going to be a lot more likely to happen in a child than in an adult. So we need child-specific research for that. The problem with child-specific research, and one of the reasons a lot of people just do not like to do it, is because it's more complicated. And the same is true with research on females. When we're talking about researching a population that has the potential to become pregnant, a lot more has to go into the work. And so when you're looking at just the sheer simplicity of developing a study, implementing that study, coming to those conclusions, and then distributing them, kind of disseminating them to the general public, it's just a lot more work to study children than it is to study adults. And when the name of the game is just getting your publications done and getting your study done, you're looking for an easier way out than dealing with children. And part of that is because sometimes we're going to need separate studies for each little subgroup of children. When we're talking about infants versus when we're talking about kind of 2 to 6 year olds versus older elementary age versus adolescents, there are a lot different components happening. If we look at the growth and development that's taking place with an infant, their immune system is still incredibly immature, it's underdeveloped. Their respiratory system is incredibly underdeveloped. We start looking at teenagers, we have this influx of hormones, we have all of these other different physiological things that are happening. So even once we get into the realm of childhood, we still can't just do one study that's on kids and generalize it to all the kids. We still have to very specifically look at these different groups to figure this out, which means instead of just taking one study on adults and saying, let's just retrofit this to everybody, we have to do the study on adults, then we need to do it on males, females, then we need to do it on adolescents, then we need to do it on elementary age, then we need to do it on the preschool, early elementary, infants, and so on, and generalize to those specific populations. That's a lot more work. It's a lot more expense. It also means we're going to have to change up those formulations a little bit. Something that maybe an adolescent can tolerate, an essential oil that maybe isn't their favorite smell, but they understand the purpose of it, it's not going to work as well on a 2 to 6 year old who's going to say, that's stinky. I'm not going to comply. I'm not going to participate in this. So sometimes we have to adjust formulations. We definitely have to adjust methodology. We have to adjust all of it to account for what we know about pharmacokinetics, which is the absorption, the distribution, the metabolism, the excretion of each of the active chemicals that are known to be medicinal in those oils. We have to then take into consideration toxicological research, stuff like we just talked about with the amount of air quality that they're breathing in. If we're looking at an infant versus an elementary age child, we know that we can bump up the concentration a little bit in an elementary age child, but still not to that of an adult. So all of those child developmental factors have to go into play. We also have to look at the fact that kids get different diseases than adults get. When we look at overall wellness and overall just kind of home health, we're talking about dramatically different health conditions in a group of elementary kids versus a group of adults. A lot of that has to do with hygiene. A lot of that just has to do with the aging process. But one very important factor related to this study is the annual incidence of a common cold. Kids who are under the age of 6 are going to get about 6 to 8 of those during the winter cold and flu season. Adults get about 2 or 3. These are also going to last a little bit longer in kids than they do in adults, which is why it often feels like kids are perpetually sick, because to an extent they are. Their immune systems are still taking in all of this information, developing all this experience, developing all of this history. And so, kind of practically speaking, for a clinical study, what this means is if we're talking about using essential oils for respiratory purposes, we've got to adjust the dosing for all of those just basic physiological differences. But we also have to keep in mind that whatever we're going to be using here for that treatment is going to be used more often in an average year than it would for an adult, because we're going to see an increased frequency. So whatever approach we're taking, in addition to adjusting their exposure and all of that, we also have to look at safety from a completely different point of view there as well. So all of those factors contribute to, first of all, why the study is so necessary. And second of all, why it's complex, why we can't just, again, speculate, pull things from other areas, try and combine it all together, and then jump to a conclusion, why we actually need to conduct this research in a pediatric population. And I will again say this is why it is so important that we have organizations like NAHA, that you guys are all involved in NAHA, because for-profit companies are not investing in this kind of research because they're able to either get their drugs prescribed off label, or in the case of natural products, they're able to convince people to extrapolate from other studies. And it's just not the best necessarily bang for your buck to invest in knowledge, to invest in safety, to invest in all of that core educational information. And this is why it's so critical that we have this, that we have these studies, because this is what really helps to make sure that when we're using our essential oils, we get those two goals of safety and efficacy both. So the study that we conducted here was specifically on kids with respiratory symptoms. So what we did, practically speaking, is we developed a blend. The kids in this study, I'll go ahead and tell you, they're aged 2 to 6, young kids. And if you look at the oils in that blend, they are oils that a lot of online sources tell you do not ever use in kids 2 to 6 ever. But the reality is parents are using them in kids 2 to 6 all the time. We're not going to make everyone stop using them. So we need to find out what we can learn about the way that they're being used, and also to figure out if some of our precautions are necessary. Because if we have something that is a safe and effective tool and we're withholding it to use something else that's untested or less tested, that's a much more dangerous approach. So instead of just kind of giving into all this, again, we dive right into this and say, okay, let's answer this. Let's get this information that we need to improve aromatherapy education, especially pediatric aromatherapy education, um, and to help the health of all of these kids whose parents are using essential oils, so we can give them guidance so these kids can feel better. Because at the end of the day, that's why all of us are doing what we do, is so that people can be healthier and feel better. So this gives us a more clear pathway to make that happen versus guesswork and speculation and online arguing and et cetera, et cetera. So we dive right into it here. Kids ages 2 to 6, peppermint essential oil, eucalyptus essential oil. We added lavender and tangerine. The tangerine in particular was to help tone down the smell. You'll recall just a couple slides back, I talked about why if we're researching with kids, something that's more tolerable for an adult is not as likely to be tolerable for a kid. Those of you with a pharmacy background are intimately familiar with that. You have to, put things into a liquid format, add flavorings and so on, because it doesn't matter how effective it is. If they don't take it, it's not going to work. So this was a kind of aromatherapy version of that, toning it down a little bit, making it a little bit more tolerable, a little softer of an overall blend, with the peppermint and eucalyptus really being kind of the king oils in this blend, and the lavender supplementing that. So that was what was used here. For safety, because we are dealing with children, then we did put it in one of those inhaler sticks. That way, if they were to touch it, and we'll talk about this in a little bit, or try and use it themselves, they weren't going to be at risk of injuring themselves. They don't have just a bottle of essential oils they could accidentally dump on themselves. And then the placebo group had an inhaler with a cotton wick inside and no essential oil. None of these oils were diluted because, again, they're in an inhaler stick, just those regular ones. That one of the first projects you probably ever made was an inhaler blend and an inhaler stick, just that regular, common, run-of-the-mill thing that we use all the time. We sent these packets out to parents ahead of time. And this is an approach that we like to take because what we know about natural products is they're most effective when you start at the beginning, because they're not only helpful at treatment, but they're helpful at prevention of things getting worse. We call that secondary prevention in public health, helping it to not spiral out of control into something that's more problematic. We want to jump in right there at the beginning. So parents who were interested in this study signed up at the beginning of the cold and flu season. They had a packet that was available to them after they provided consent and the children provided informed assent. And then if they developed two or more respiratory symptoms, then they opened the packet and had instructions on how to use it. So these were there for literally the very beginning onset of symptoms, right off the bat. And I'll give you just a little quick teaser of a study that we have coming up this summer. Also on children, we're looking at using essential oils for first aid. We're taking a very similar approach with that. So we can get the second something happens, that immediate treatment effect, because we know that's where we're going to see the biggest effects overall. We know from past research, and also we all know from experience, that if we wait till something is out of control or out of hand, then we're going to often need a much bigger solution than something that is also preventive. So when they developed these two symptoms that they developed, and it had to be any two respiratory symptoms, so they couldn't just, cough and pull out the aroma stick. It had to be two actual respiratory symptoms. Then each parent opened their packet with their aroma stick in it, and they would hold it within an inch of the child's nose. So the inch was our way of controlling that exposure, because again, everyone's idea of breathing in from an inhaler stick is different. So this gave us that consistency across the board. They would start right away and they would hail for 1 minute, and then they put it back in the pouch. And then they set the timer for an hour, and then they did it again. So they did it each hour for a minute at a time. So there were 7 total applications here. Now, we've conducted very similar studies in adult populations with proprietary blends from different companies. And with those, we'll often do it hourly around the clock until they start to feel better. But remember, we just talked about how kids have cold and flu symptoms and just cold and flu incidents that are a lot more frequent than adults. So here we wanted to specifically look at, if we have just this 6-hour intervention, what effects are we going to get from this 6-hour intervention? So that way we can continue using it even though kids are getting sick more frequently. So that was kind of the key factor we're looking at there. Now, one of the questions we got when we talked about this at last conference, we talked about the fact that the study was wrapping up and that we had a little bit of a sneak peek at some of these results, is why not use a diffuser? And there's a lot of reasons for that. One of the biggest reasons, though, is again that physical size, that smallness of children comparing to adults. So not only are they breathing in more air than adults are, but they're shorter, right? Because they're children and they're not fully grown like we are. And we know from clinical studies in environmental health that the air quality in your home or even outside differs from zone to zone. So the higher up you are in your house, the cleaner your air quality, because so many of these particles tend to concentrate in lower levels closer to the floor, which means the little ones crawling around the floor or who are only a couple feet tall are actually breathing in more toxic air than the adults in the same home. And we see this in different studies. There was a study about parents walking down sidewalks with their children, and the car exhaust pollution at their breathing level was far higher than at the adult's breathing level, which was a couple of feet higher in the overall air. When pushing a baby in a stroller, they're going to be breathing in a lot more air pollutants than an adult. So when we're diffusing essential oils through a room, if we're comparing it with an adult's sense, which is the approach a lot of people take, I'm keeping an eye on it, I'm smelling it, it feels fine for me, or I can barely smell it, we might need to turn it up, we need a little bit more. We're breathing in from one zone. What they're breathing in is a different zone. When you combine that with the fact that they're breathing in more air from that zone than we are up here, you start to see dramatic differences in the total amount that they're exposed to. Another reason we didn't use a diffuser for this is simply because diffusers are always going to be proportionate to the size of the room. So if we're talking about a child who's playing in a living room, and that living room has a 2-story ceiling and is an extremely large open floor plan living room, and the windows are open because it's a nice breezy day, maybe going and taking a nap in a bedroom with the door closed and the windows shut because it's raining outside. So we're going to get different concentrations of that oil in the air that these kids are breathing. So we can't really standardize that exposure which means we can't glean from this study information about how much oil these kids should be breathing in. So using an inhaler stick and then standardizing how close they're using it to our nose helps to standardize that dosing recommendation that we can now make. Another reason is safety. If we did have a child with an adverse effect in this study, and there's an inhaler stick and they're breathing it in close to their nose, it is very easy to get rid of it. Put the top back on, put it back on the couch, take it to the outside trash, it's gone. You can't do that if you've already diffused it throughout your house and you do have an adverse effect. And since this is a topic that so many people are concerned about adverse effects, and that was an outcome we were absolutely measuring and checking in on, then we needed an easy way to immediately eliminate the intervention if that was necessary. So a lot of practical safety and methodological reasons that we use that highly controlled aroma stick. For practical purposes, it also has a lot of benefits because it means if we're trying to replicate these results in the real world, it's really easy to keep an aroma stick on hand with the blend already in it and pull it out of your diaper bag or your purse or your car, wherever that might be that you have it. So it's a lot easier to use this on the go. So we had a total of 112 children in the US participate in the study. So signed up, provided informed assent and consent, and had their pouches ready to go. And of those kids, during the time period we were studying them, 68 of them developed symptoms, which again is a lot of them, but keep in mind we're talking about 2 to 6-year-olds, so they're getting a lot of colds every year. So that was about what we expected. The number we needed for the power analysis was 58, so we got the properly powered study with those 68 kids that developed symptoms. And again, they had to have 2 or more symptoms. So they had to have an actively runny nose. They had to be sneezing. They had to have watery eyes. It couldn't just kind of be they woke up, coughed a couple times, and we pulled up in the pouch. We had to actually be seeing symptoms here for them to qualify to begin. And then the pre-specified outcome that we're looking at was, again, the incidence and severity of their respiratory symptoms. So how many symptoms did they have at the beginning and end of that 6-hour intervention with 7 total exposures? Did it reduce the total number of symptoms that they had? And did it reduce the severity? Because both of those factors matter. Are we actually helping to make this go away? We didn't look at, are we curing the common cold? We didn't turn this into a dichotomous outcome and say, how many of these kids at the end of the 6 hours were completely healed and up and playing? Because we know that when we say that something is working in the natural health world or in the pharmaceutical world, that it's not necessarily an instant cure. We know that it is improving your overall well-being. So that's what we wanted to know is, are we making things easier and better for these kids? Are we helping them on the road to recovery? Are we seeing their symptoms actually start to fall down? So a little bit about what we're looking at. We defined prevalence as the presence of any symptoms within that period. And then we also measured those for severity. So again, just clarifying here, the total number of symptoms and then how bad were those symptoms. The scale that we use also measures things like how well are you able to actually go about your regular day? Is this interfering in your overall quality of life? Are you able to kind of continue doing things you would normally do, or are you completely bedridden and in bed? Because again, those might both technically be sick, but we've all been there. If you can get up and you can still do routine things around the house, it's a lot different experience. So the same with the kids here. We're looking at what of their routine activities were they able to maintain during this time period. So for respiratory specific symptoms, here's the good stuff. For respiratory specific symptoms, in the placebo group, the average was 4.3. And the standard deviation basically gives you that variance because we're talking about humans, and humans are so diverse and varied. We all have different levels of cold and respiratory symptoms and so on. So some of them had, again, just like the 2, some of them had a lot more. 4.3 was the average. 3.62 was the average in the essential oil group. So obviously we see that as lower. We see that reduced. So we start comparing these to look for statistical significance. And what we found is we were just above the cutoff here. Our p-value was just above. Um, but we went ahead and calculated an effect size because with a group this size and with numbers that size, again, there's nothing magical about 0.05. That's just kind of the standard that's accepted. Having it be that close is scientifically and therapeutically relevant. So we calculated our effect size as partial eta squared, which is classified as small to medium. What does all of that mean? Basically, when we're looking at an effect size tells you basically, like the word says, the strength or the size of the effect of that intervention. So if we start out here, can we expect it to have a dramatic drop or just a little drop? Practically speaking, and in something that might be a little bit more familiar, is if we're talking about hypertension, and we have a dietary supplement that we're taking to measure blood pressure. If we have a drop of, 2 points, we might have a sample size that's big enough to say this is a statistically significant drop. But 2 points is not a therapeutically significant drop. That's not going to be really the approach we want to take or the goal that we want to have if we're investing our money into trying to drop our blood pressure levels into something that's in a reasonable range. 2 points isn't going to do it for us. If it's going to drop at 20 points, that's a much larger effect size. So we power our studies typically to find a medium effect size or higher. We don't power them really for the smaller effect sizes. The reason we target medium effect sizes, especially in aromatherapy, is because these are things that are typically self-prescribed. And studies have shown us that a medium effect size tends to be an effect that's large enough for the participant or the patient to notice on their own without having to have some sort of external measurement or validation that there has actually been a change. So this is something that would typically be the level at which you go, I'm starting to feel better actually now that I think about it. This is the medium effect size is kind of where that starts to happen. So seeing a small p-value basically tells us we found exactly what we expected to find. If we'd done maybe a bigger study, we might have statistical significance, but we see that difference. So then when we evaluate it and we take away other factors that might also be playing a role here, and we control it for age, whether or not they were a boy or a girl, all of these other factors, then what we have are adjusted symptom scores. So this is what it would look like if the only difference between these two groups was the intervention. And here we get, you notice the placebo group went up a touch, 4.38. And then the aromatherapy group went down a touch, 3.54. So that is kind of the average, basically reducing it from just over 4 symptoms to just over 3 symptoms in a 6-hour span. That's pretty remarkable to see that happen in a 6-hour span. It's almost a 25% reduction in the number of symptoms that you're experiencing. So what we did here was we dug deeper into the data to say, okay, there's clearly areas that we're seeing these reductions. What is contributing this? So we evaluated these different symptoms that we were looking at to find where are we actually seeing these big changes that are leading to this overall trend that we're noticing. And then we also looked at establishing an odds ratio, which is going to be similar to the risk ratio we talked about earlier to show the odds of having that symptom in one group or the other. This helped us to find out that sneezing and itchy eyes were the two areas that the blend really helped to eliminate within that 6-hour period. So within that immediate 6-hour period, those two had significantly reduced. So we have that big effect size, statistical significance, and that massive reduction that's big enough for somebody to notice. The other areas that we saw that were again trending towards significance where we saw dramatic changes between the groups were clear breathing, post-nasal drip, and fatigue. And the fatigue is, one we could have kind of expected. Breathing in peppermint for 6 hours is going to help boost energy levels. But those are the other areas that we see that it starts to really help out. So here is all the statistics for those of you that want to dig into all of that. You can see the uh, odds ratio here. You can see the chi-squared. You can see all of that we have in here. Essentially, those who breathed the essential oil blend were about as fourth as likely to experience sneezing afterwards. The ratio there was 0.28. And so again, just like we talked about earlier, the one-to-one is where you have the same uh, risks. And here the p-value is 0.027. And then with watery eyes, we saw 0.053, so we're kind of right there on the cusp. And then our risk ratio there is 0.13, so 13% is likely, a lot less likely to have watery eyes afterwards. We had some other outcomes that were also noteworthy. And the reason this is noteworthy, even if some of these were not statistically significant, is because they're dramatic differences. So when we look at whether or not we're going to achieve statistical significance, the size of the group in the study, again, plays a big role. Um, if you don't have a lot of people develop certain symptoms, you don't necessarily have enough numbers to compare to see some of those differences. So when we're looking at the full study and we look at those small to medium effect sizes, again, I mentioned the study's powered, which basically means just the size of the study was established so that we could identify a correct effect size, that we are not going to accidentally get false results. When you have really, really rare circumstances or outcomes, you need a lot more people to find them. So the study wasn't powered for each individual symptom, it was powered for overall symptoms. So digging into these data kind of speak for themselves, but there's not necessarily enough in here of all of these to statistically analyze. For example, body aches. There was only one child who had body aches at the end of the intervention with the essential oil blend, but there were four in the placebo group. So that's a big difference. It's just those are small numbers when we start doing statistics on them. Only one had difficulty breathing, but four kids had difficulty breathing in the placebo group. And then postnasal drip, the direct numbers, we already talked about the statistics on that one, were 7 in the aromatherapy group and 13 in the placebo group. So the statistical significance and all of that is important, but here's kind of the real world effect. This is the specific number of children in this study who experienced improvement just from breathing in this essential oil blend during that time period. We also get subjective feedback. And this is important for a lot of reasons. We always get subjective feedback anytime we run a study because it's going to give us, first of all, just the open opinion of someone who's undergoing an experience. It tells us a lot about what group they thought they were in because we do compare how well blinding worked and how well the placebo effect worked and how much it contributed. It also gives us information that's useful for maybe modifying the approach that we use. And so here we got a lot of information directly from the kids and their parents, talking about a lot of the kids at the beginning were a little hesitant. A lot of them did not like the smell at the beginning. And then by the end of the study, several of them were grabbing the aroma sticks and using them themselves. One of their kids said that the blend smelled like Whole Foods. Several of them said it smells yucky or spicy. One of them says, I'm running out of smells, Mama, as they got close to the end of the study. Another one said it smells lemony and orangey at the same time. A lot of the kids kept monitoring the timers for when they could start using it again. Again, a couple of them at the beginning weren't sure of it and then really warmed up to the idea. At least 2 or 3 of the kids wanted to keep using it after the study. And then again, several kids started trying to grab the aroma stick themselves and use them themselves. So overall intake was really great. Again, a little bit of hesitation at something new, unfamiliar at the beginning of it, but kids really warmed up to it, enjoyed using it, which is great because when kids have respiratory symptoms, there's not much they really enjoy doing. So having something that can be a little bit fun and is helping them to breathe better is a big win. So takeaway, intermittent exposure. So again, 1 minute every hour for a period of time has been shown to be safe and effective for reducing upper respiratory symptoms in young children, 2 to 6-year-old kids. The kids that were in the study enjoyed participating in it. But again, another piece of takeaway, and this is again why subjective information can be so important to collect during a study like this, this does demonstrate, the kids want to be hands-on and active with it, having those closed containers, using the aroma stick or another device that's specifically designed for children so that they're not accidentally dumping anything on themselves is critical here. Because keep in mind the age group here, we're talking 2 to 6-year-olds, so we're talking toddlers. So having it safe that they can grab and they can touch and they can find and explore is critical. We see that because we see they're very interested in having it. There were no adverse effects found in either group, and we monitored throughout the entire study. We also monitor after the study. So we monitor for, depending on the study, a week or two, sometimes even a month after the study, we continue monitoring for the development of anything that could be classified as an adverse effect. So there were no adverse effects that were found in the entire study. So what this means practically, how we can utilize this information practically, is first of all, we know now with certainty that these oils are safe to use in this population. They're going to be effective to use in this population. We don't need a lot. We don't have to pour it through the house the minute they start getting sick and keep it running. We don't have to douse them in it the minute they get sick. We can use some of the most basic aromatherapy tools that we all learned in our earliest aromatherapy classes, and we can make a dramatic difference in the well-being of even some of our youngest aromatherapy community members. So that's the takeaway here and the importance of that study. Okay, so if any of you do have questions, go ahead and type them in the chat. I am going to tie this to kind of next steps and what we're doing from here. Obviously, you guys know my excitement about when we study some of these questions that just tend to get neglected. And, we've spent years back and forth and arguing online about using these essential oils in this population and what is safe and what is effective and what does dosing look like and so on and so forth. And, diving into that and settling some of this and having that clear guidance is so critical for the future of this field as a whole. And you guys know that this is NAHA's known for this. NAHA does this. We did this with the tea tree and lavender and prepubertal gynecomastia argument that just kind of went on for over a decade. And then we dove into it and said, let's answer this. Let's see, is there a link? If there's a link, what is contributing to the link? And if there's not a link, let's stop with the fear mongering. And so the next thing we're looking at doing is, again, we have some studies underway. Right now we have one wrapping up that I'll be presenting at the conference this fall. So I don't want to give any sneak peeks of that because that's for the conference. But we are starting a trial this summer looking at the use of lavender essential oils in very high dilutions for wound care, specifically first aid with children. So it'll be run kind of similar to this, where parents will provide informed consent, children will provide assent, and they'll have these packets ready to go in their first aid kits. And when they, are playing outside or whatever they are, and they have those cuts and scrapes, we'll be evaluating, again, those wound healing properties so that we can quantify it, so that we can better address dosing concerns and make sure that we're actually using enough to achieve the effects we need to achieve, and then establish some clear and safe guidance protocols there as well. So you're going to start to hear more about that, but that one's literally kicking off within the next couple of weeks. It's just in the very early stages of that, but you're going to start hearing a lot more about that in the coming days and weeks as well. I do see, when will this be published, Carol? We've actually just submitted our final draft to the NAHA board within the last couple of weeks. And so then we are targeting journals to submit it to within the next week or two. And then who knows? Peer review these days is sometimes really slow, sometimes really fast.
Yeah, I just wanted to remind everyone of the conference this October. If you're interested in browsing through the speakers or purchasing a ticket, just visit our website at conference.naha.org. And then as Dr. Cavanaugh, she was just giving us more information about the other clinical research studies that she's going to be doing. Those will be posted on our um, NAHA website also, so you can find more information there. And then once these results are published, we'll update it on our website also, so that you can have access to reading it. Kelly said, "So excited for your conference presentation in October. We appreciate all you and your team's hard work with aromatherapy research. Thank you."